From Microbe TV, this is Infectious Disease Puscast, episode 91, recorded on Monday, October 13, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and unfortunately, this is solo. No Dr. Sarah Dong today, but she will be back in 2 weeks. She's busy with her clinical and teaching responsibilities, so I guess this teaching responsibility didn't fit in this time, but she will be back. So without the banter, we will just move forward. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. And now on to the literature, shall we? I'm going to start off with our viral section and reminding all our listeners to listen to TWIV, This Week in Virology, both the clinical update and the deep dive. Sometimes things kind of at both areas, but sort of try to have each of them stay a little bit in their own lane. So if you listen to both, you get more of a full picture of what's been going on. But let us start off with the first article, the article comparison of 2 doses versus 1 dose in the first season. Children are vaccinated against influenza, systematic review and meta-analysis published in JAMA Network Open. I feel like this one I may have actually also discussed on the clinical update because it was just that good. And some of the things I mentioned on the clinical update, we always keep talking about influenza. And one of the things I like to try to remind everyone is that influenza really causes considerable pediatric morbidity and mortality. An estimated 20% of children, so 1 in 5 children each year, are infected. Children younger than 5 have the highest hospitalization rates for influenza of any age group. Get that? Under 5, highest hospitalization rates for flu of any age group. Last year, almost 300 children got sick enough that they died from the flu. So the WHO recommends that flu vaccine naive children aged under 9 receive 2 doses of influenza vaccine at least 4 weeks apart, with 1 dose each year thereafter. AAP, the American Academy of Pediatrics, recommends that children aged 6 months through 8 years receive 2 doses of flu vaccine in the same season if it's their first time. So think about it as the first time your child has not gotten the flu shot before, you get 1. 4 weeks later, boom, you get the second, and then after that, it'll be a yearly. That's great and all, right? That's American Academy of Pediatrics, that's CDC, that's WHO. But here these researchers ask the very important research question, which is, does research evidence support a 2-dose schedule in the first year of vaccination for influenza vaccine-naive children younger than 9 years? They performed a meta-analysis that included 51 studies, 415,050 participants, to estimate the increase in vaccine effectiveness of a second inactivated influenza vaccine dose. The pooled absolute increase in vaccine effectiveness of a second inactivated influenza vaccine dose in the first year of vaccination was 15 percentage points for those younger than 9, and 28 percentage points for those younger than 3. So really making a big difference, in the sort of the highest risk group. Some really nice figures. There's a nice figure 3 where we get forest plots. There's another figure 2. I'm kind of doing these backwards, where you look, again, getting forest plots. So really nice, really compelling data saying that those recommendations do make sense. All right, and so for more virology-related stuff, be sure to listen to Clinical Update. All right, moving right into bacterial. This is really going to be the meat of what we're talking about, I guess I will say, on this Infectious Disease Puscast. A lot of interesting articles. So bacterial, be sure to listen to This Week in Microbiology. A lot of great stuff I was just listening to today about how the microbiome is associated with increased risk of pancreatic cancer, how the oral microbiome actually influences sleep and frailty. Fascinating stuff. Well, here we have a couple articles. And the first article is Performance of Different Versions of Duke Criteria in Diagnosing Infective Endocarditis in Patients with Intracardiac Prosthetic Materials, published in Open Forum Infectious Disease. So the authors start off the article with the sentence, diagnosing infective endocarditis is a significant challenge. And I like that opening sentence, as I think it can be often overlooked in retrospect or once the time has gone by and all the information is then available. When we see the large vegetation, have persistently positive blood cultures despite 24 hours of appropriate antibiotics, it seems so straightforward. To perhaps demonstrate how the challenge here is that this study brings up that the Duke criteria is not the only criteria employed in making this diagnosis. So the study aimed to compare the diagnostic performance of the 2015 and 2023 European Society of Cardiology and the 2023 International Society for Cardiovascular Infectious Diseases, ISCVID, Duke clinical criteria in a cohort of patients with suspected infectious endocarditis and intracardiac prosthetic material. So for background, because I think, I guess I sort of came into this game in the middle. I was not a practicing physician in 1981, but the first Duke criteria were published in 1994. And these replaced the 1981 Rhine Beth Israel criteria, right? So quite a gap there, right? Say 13 years. We'll talk about why. So then we get the 1994, the first Duke criteria, and then we get a number of validation studies. And then in 2000, we get the updated modified Duke criteria, so published in 2000. And then we have this gap until the most recent, at least when it comes to Duke criteria, a gap until the most recent Duke criteria updated in 2023, right? So for 23 years, we've been using the same modified Duke criteria, but here we get the most recent Duke criteria updated in 2023. And we discussed that updated 2023 Duke criteria on the Infectious Disease Puscast 28, and I'll leave a link in there. Sarah was discussing that. So here we have the results of a retrospective study conducted at 2 Swiss university hospitals. The reference standard was the diagnosis of the endocarditis team or expert clinicians. Patients with infectious endocarditis, the reference standard classified as definite infective endocarditis by the Duke criteria considered true positives, while those without infectious endocarditis classified as rejected, i.e. were considered true negatives. So just sort of what's going on here and why are there all these gaps between? So you come out with criteria, the expert panel puts these out there, and then you end up with studies like this where they look through and they basically test the criteria. Do they work? Do they actually validate when we look at them? So of the 1,025 episodes with suspected IE, infective endocarditis. I'm just going to say endocarditis, but now I guess I'll say infective endocarditis. So of the 1,025 episodes with suspected IE and intracardiac prosthetic materials, 61% had IE. Using the 2015 ESC, 2023 ESC, and the 2023 ISCVID, that's the updated Duke clinical criteria, 32%, 36%, and 42% episodes were classified as definite IE, respectively. They calculate sensitivity for the 2015 Duke, the 2023 Duke, the 2023 Duke, and so that's a 2015 Duke ESC, the 2023 Duke ESC, and the 2023 Duke ISCVID. The clinical criteria were calculated to be 56%, 61%, and 71%, while the specificity was 67, 56, and 34% respectively. So really interesting here, right? That in this context, in this validation, the specificity of the 2023 most recent Duke criteria is only 34%. So equally worrisome, you might say, was that the sensitivity for these different criteria ranged from 56 to 71%. So you're really missing some when it comes to sensitivity, but also you're overdiagnosing with a specificity of only 34%. So they conclude that the 2023 ISCVID Duke clinical criteria demonstrated the highest sensitivity for diagnosing infectious endocarditis in the presence of intracardiac prosthetic material compared to the 2015 and the 2023 ESC, right? So European Society of Cardiology criteria. However, this increased sensitivity came at the expense of specificity, which was lower with the 2023 ISCVID most recent Duke criteria. Notably, the improved sensitivity and reduced specificity were largely attributable to the inclusion of newly classified typical microorganisms in the presence of prosthetic intracardiac material. All right, so with that context, is it okay to wait a little to make sure we have the diagnosis? Should everyone just be thrown on antibiotics when they hit the door just because it's in the differential? Well, in Open Form Infectious Disease, we have the article with a title that catches the eye: Infective Endocarditis and Antimicrobial Timing, a case for delay, ? In patients with suspected infective endocarditis, current guidelines recommend prompt initiation of empiric antimicrobial treatment after obtaining blood cultures. However, the clinical benefit of immediate treatment in hemodynamically stable patients remains uncertain. So this study assessed the impact of deferring antimicrobial treatment in patients with suspected IE. Here, the investigators conducted a multi-center cohort study of adult patients with bacteremia and a clinical suspicion of IE, infective endocarditis, from 2 university hospitals. Patients presenting with sepsis, ICU admission, neutropenia, or clearly identifiable focus other than IE were excluded. All cases were adjudicated by a dedicated endocarditis team as either IE or not IE. The primary outcome of all episodes was 30-day mortality for confirmed IE cases. The composite outcome included 30-day mortality, new embolic events, or new bone and joint infection. Among 1,230 episodes, empirical antimicrobial treatment was initiated immediately. That's our group 1 after blood culture collection in 675 episodes, and deferred until preliminary blood culture results, group D. Maybe that's group I and group D. I couldn't figure that out in 555 episodes. 30-day mortality was not different between groups I and D, 5% versus 5%. Of 597 confirmed IE episodes, 49% infective endocarditis, 55% were in group 1, 45% in group D, group I, group D. The composite primary endpoint 30-day mortality, new embolic events, or new bone and joint infection occurred in 28% of the group where antimicrobial therapy was initiated immediately, versus 24% in the group where they deferred start of antibiotics until preliminary bone blood culture results were available. I'm going to point out, because I don't like the trend issue. Despite this trend toward better outcomes in patients where antibiotics were deferred, this did not reach statistical significance. We've got a p-value here of 0.304. So really nice graphical abstract for infective endocarditis and antimicrobial timing, a case for delay. Maybe a case of saying, there's no harm with delay. Despite the trend, I'll say no statistical significance, and really nice here as they have in this graphical abstract. 5% 30-day mortality starting right away. 5% 30-day mortality, waiting for those preliminary results. Okay. All right. And MMWR. Oh my gosh. People who are following the news may be aware that there's a little bit of an issue going on or not. We're not sure that everyone at the MMWR at the CDC was fired or not, depending upon the hour. So they got a message you were fired, and some people got a message you weren't really fired. April Fools. who knows? But, just my heart goes out to the people at the CDC. And another example of the great work with the MMWR, tularemia, antimicrobial treatment and prophylaxis, CDC recommendations for naturally acquired infections, and bioterrorism response. United States 2025 seems to have caught people's attention as I get emails and see YouTube comments. So here we have, again, a nice graphical abstract. But for background, we read that tularemia is a rare but potential serious disease caused by Francisella tularensis, and a highly infectious non-motile gram-negative Coccobacillus. F. tularensis is endemic throughout the Northern Hemisphere, with the majority of annual infections reported from the United States, Turkey, and Northern Europe. Approximately 200 to 300 cases of tularemia, also known as rabbit fever or deerfly fever, are reported in the United States annually. Cases have been reported from every state except Hawaii. I suspect there's an issue with underdiagnosis, but let us continue. Humans can be exposed to F. tularensis through various routes, including bites from arthropods, ticks, deer flies, and mosquitoes, cutaneous exposure through butchering and other contact with infected animals, ingestion or contaminated food and water, contact with contaminated soil or hay, and inhalation of aerosolized particles. On the boards, you're always skinning a rabbit and cutting yourself, or maybe getting, finding ticks from that rabbit you're skinning all over you. Who knows, by the way? In 2012, F. tularensis was classified by the U.S. Federal Select Agent Program as a Tier 1 select agent, indicating the greatest risk for use during a bioterrorism attack based on its history of weaponization, stability in the environment, and an infectious dose as low as 10 organisms. Ouch. Now, the U.S. and the Soviet Union included the bacterium in their biological weapons stockpiles during the 50s and 60s. These countries, as well as Japan and the UK, are known to have researched the bioweapon potential of F. tularensis. They've got a nice reference that you can go to there. Now, one documented U.S. study during 1966 to 1967, Operation Red Cloud, involved mechanical dissemination of Francisella tularensis into an Alaskan forest to investigate distribution and decay rates. I'm going to leave a link into here to the article, Tularemia, A Storied History and Ongoing Threat. If you want to read more about this stuff, they have a nice section in this article that goes through some updated changes. The article also has lots of great tables. So keep this one bookmarked, for when you see one of those cases. I expect UpToDate and other resources to incorporate these recommendations. So, they go through treatment recommendations for adults and children. When treatment initiation is delayed, Cipro, Levaquin, or gentamicin is preferred over doxy. Treatment duration, 10 days. Really some nice recommendations, treatments for pregnant women, post-exposure prophylaxis. So, great stuff there. But, the drugs we're thinking about here are doxy and the fluoroquinolones in general. All right, moving on to fungal. We have the article, Risk Factors Associated with Progression to Clinical Candida auris Infection Among Adults with Previous Colonization, Florida 2019-2023. So here they identified 105 case patients with documented clinical specimens after colonization and 578 control subjects with colonization only. Factors significantly associated with clinical cases included presence of 5 or more COVID conditions. That's going to give you a 10-fold increase. 4 or more invasive devices, odds ratio 2.92. And 3 or more recent medical procedures, odds ratio 2.32. Also, fully dependent care required for eating, odds ratio 2.8, mobility 2.15, and transferring 1.82 were associated with clinical case progression. So really nice seeing here that, when you're comparing folks that are colonized with C. auris and folks that are actually infected, there tend to be a number of different characteristics. All right, and now we're going to move on to parasitic. And be sure to listen to This Week in Parasitism. We just this last Friday recorded the answer to our recent mystery case. And I'll say our emailers did quite well there. So be sure to listen to This Week in Parasitism. But I was just actually talking about this today. I was thinking of heading back to Africa this December, but it looks like I could just stay here in the U.S. and see cases of locally acquired malaria. The article, Public Health Response to the First Locally Acquired Malaria Outbreaks in the U.S. in 20 Years, was published in JAMA Network Open. And they start by asking the question, why were there 4 outbreaks of domestic malaria in 2023 after 20 years with no locally acquired cases? Now, in 2023, the U.S. reported 10 locally acquired mosquito-transmitted malaria cases of 4 genetic lineages in 4 states. The first such outbreaks detected in 20 years and the largest in 35. The qualitative study was an interdisciplinary public health response to the locally acquired malaria outbreaks in May to December 2023. It included case investigations, enhanced case finding, PCR analysis of captured Anopheles mosquitoes for Plasmodium parasites, novel targeted amplicon sequencing of Plasmodium in patient blood samples. Public health interventions included incident command activation, clinical outreach, community awareness, vector control. Patient data were acquired through public health surveillance as part of national notifiable disease surveillance. So this study included 10 patients, mean age 39.5, 70% were male from Florida, Texas, Maryland, and Arkansas with locally acquired mosquito-transmitted malaria, and 783 Anopheles mosquitoes across 4 states. No patient had a recent history of international travel or bloodborne exposures. Outbreak cases had an epidemiological link within, but not across state lines. P. vivax was detected in 3 Anopheles crucians in Florida. Sequencing data showed that all Florida P. vivax cases shared the same Plasmodium strain. The Texas and Arkansas P. vivax cases were genetically distinct from each other and from Florida's cases. All 9 P. vivax strains had genetic signatures that were consistent with Central and South American origin. Maryland's P. falciparum parasites were consistent with African origin. The outbreaks, as I think we're aware of, were contained. So some great figures, but I just want to walk through these a little with us. So maybe David will have these up on the screen for the YouTube watchers. So Figure 1, number of imported malaria cases by species in the U.S., and this is 1972 to 2022. We see our COVID dip right in 2020 and then right back up there. But you can really see total cases rising over time. You can actually see the Vivax cases actually trending down and really seeing more falciparum cases. Figure 2 is great because you could really look at, number of malaria cases by U.S. state. And you can see there really are places where this clusters, right? And as we discussed, these folks, somehow the mosquitoes are getting it. They're in our country, and so we're seeing it there. But here, this is just total number of malaria cases by state, right? Most of these, right, are people coming from, as we see here, south of the border or from sub-Saharan Africa, but also we have had cases, where folks come from Asia. But you can see which are the hot states, the greater than 58, California, Texas, Florida, Georgia, Virginia, Maryland, New York, New Jersey. Interesting enough, we also see Massachusetts, Ohio, Minnesota. And then figure 3, I really like. This is a timeline of locally acquired malaria outbreaks by species in U.S. states. They go from 1980 up to 2023. And they actually have a couple of these outbreaks. The little outbreak in California in 86 with 28 cases, another California in 1988 with 30 cases. And then you see just a little bit going along. And then, we see boom, these recent, outbreaks in 2023 with the one in Maryland, the one in Texas, the one in Florida. All right. And wrapping us up, this is going to be a shorter one this week. The article in Miscellaneous, Fever in Sepsis Revisited. Is a little heat what we need? This was published in Open Forum Infectious Disease. And I have to say, this should be a required reading. Whenever fever comes up on round, I wax eloquently about what is a normal fever and all the variation that goes in. But maybe more importantly is we're so quick to treat fever. What should we be doing? Well, here they discuss studies with, are you ready for this? Improved antibiotic MICs with higher temperatures. It was a really nice graphic where you can see if you're above 41, truly hyperthermic, or if you're below 37 C, truly hypothermic, you really kind of want to get into this range. But actually, as you're seeing, if you're at these higher temperatures, you can get better antibiotic MICs. They also remind us, and this is something we've covered recently, that antipyretics can actually increase microbial mutation frequency. They mentioned some studies of septic ICU patients, no clear mortality benefit, potential harms with, interesting enough, external cooling, sort of arguing here for, oh my gosh, acetaminophen or Tylenol. I know why everyone calls it Tylenol. It's hard to say paracetamol or acetaminophen. At the end of the day, I have to say, we need more science here. Are we actually helping our patients by treating those fevers, or are we thwarting an ancient adaptive response in mammals to infectious challenges? All right, well, that brings us to the end of this Puscast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire. You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher, or on YouTube, where you can subscribe, like us, ring the bell, leave those wonderful comments. I have to say, the comments are much nicer for Infectious Disease Puscast than happens for some of those other shows. We'd love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. If you like what we do, or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or Parasites Without Borders, and click on the donate button. Sarah Dong will be back in 2 weeks. In the meantime, you can find her on Blue Sky at sarahwindong.febrilepodcast.com or at febrilepodcast.com. I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye. Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.